So, welcome everybody, and I thank the organization for the opportunity to talk about my experiences with nociception level in monitor and how I introduce it into my clinical practice. So I'll try to make this a practical lecture mixed with some references to the evidence and also with some background on how I look towards nociception level monitoring. And then in the second lecture, we probably go some more into detail on thoracic surgery. So my name is Hugo Vereecke. I'm a consultant anesthesiologist in the General Hospital AZ Sint-Jan in Bruges in Belgium. And I also am an assistant professor in the Netherlands in the University Medical Center in Groningen. Yes, there it responds. So my clinical and academic expertise is mainly focused to anesthetic pharmacology. And in my research, I mainly focused on intravenous anesthesia, and I was involved in the development of optimal models for target-controlled infusion pumps. I mainly focused on propofol and remifentanil, but once I started working on drug interaction models, I also introduced the interaction between volatile agents, propofol, and different opioids. I have some expertise on EEG monitoring and how it relates to the hypnotic component of anesthesia. And now, therefore, I'm very interested in the new technology that quantifies the nociception anti-nociception balance. And NOL monitoring certainly has made an impression on me. If I want to do this in clinical practice, I need some technology. And for me, if I want to give my drugs intravenously, both for my hypnotics, for propofol, as for the opioids, I like to work in target-controlled infusion modes. I will explain you later why. A second form of technology is monitoring. And of course, like everybody, I first monitor the heart rate, blood pressure, saturation monitoring. That's for the survival of the patient. But I like to add a specific EEG monitor to quantify the hypnotic effects of my drug mixtures. And I now recently add an analgesic monitor, or a monitor of the balance between nociception and anti-nociception, like the PMD200. And these two devices help me to individualize the titration of my drugs. So why target-controlled infusion? I think you can get some better control on your pharmacology by trying to get some control over the time course of your drug effect, both the hypnotic drug effect and the analgesic drug effect, as fast as possible. And you try to have a steady state as fast as possible and without overshoot of effect. And I find target-controlled infusion, whenever you have an appropriate model for your patient, a very suitable tool. A second goal, which I will explain in more detail, is that in a second phase of my induction, I want to fast identify the individual needs and whether my patient is a sensitive or rather resistant drug responder compared to the average expectations. And then the monitors really become useful. And the third goal is to, once I have my steady state adapted according to the individual sensitivity, I will start adjusting my mixture based on the anticipation of noxious stimulation. So this is just a visual impression of what I explained before. Why do I think in terms of effect site concentration, for example, in this example for propofol? Because the time course of an estimated effect site concentration really mimics the time course of the clinical effect. And the example for this is if I target effect site concentration of propofol to 4 micrograms per milliliter, in first patient, this could be the BIS, around 55, and with a time course that kind of looks like the effect site concentration of propofol. The second patient might have a completely different BIS, This one is much more sensitive and has a much lower value, but look at the time course. And the third patient might be more resistant. Again, you will have different BIS values for every effect site concentration of a certain drug, but you will have some control over the time course of that effect. And also when you give a bolus and a continuous infusion of propofol, you will see a time course in your effect that is kind of mimicked by the effect site concentration that is in the background. If you simulate the effect site concentration in the background, you will see a peak concentration first, and then a decay of your concentration over time, depending on the pharmacokinetics of the drug. And then you set up a continuous infusion, and somewhere along the line, you will reach a steady state, but often a bit later than with the TCI pump. And if you look at the BIS, indeed, you often will see this pattern with an overshoot in the beginning. Of course, different patients will have different peak effects, but still the time course is more or less controllable using a TCI algorithm. And again, you have two advantages. First, you avoid this zone of overdose, and you have more and a faster control on a steady state. Now, for the hypnotic drugs, that's really feasible because we have really good descriptions of the dose-response relationship between your effect site concentration of propofol and an EEG monitor such as the BIS. What can we do with this? We can target all our patients to a single effect site concentration, for example, 5 micrograms per milliliter. And then you will see, if you do this in 100 patients, that your average BIS will be 50 in that population. And due to the Gaussian distribution in the biology of many factors in biology, you will even see that the majority of your patients with one setting will reach a clinical acceptable depth of anesthesia. Of course, you can't know this in advance. You may have one patient who is really sensitive and have a very low BIS compared to the expected average. Another one could be very resistant. And therefore, you need to adapt your effects, your initial target, to a higher level for the resistant patients in order to reach the same BIS of 50, and to a lower level, to a target of 2 for this very sensitive patient. And so this is the strategy that you use to individualize your initial effect site target to the patient's need. Now, can we do this for the opioids? This is a bit of a problem because at first we didn't have monitors to quantify the analgesic potency of our opioids. And therefore I use the interaction models. And because these provide very useful information, which combination of a hypnotic and an opioid gives you an effective probability of tolerance of laryngoscopy. And for example, I like to start my anesthesia in the majority of my patients with 4 nanograms per milliliter of remifentanil using the Minto model, and 4 micrograms per milliliter of effect site concentration of propofol using the Schneider model, because the interaction models predict that my probability that the patient will tolerate laryngoscopy is above 90%. So that means if I repeat this induction in 100 patients, only 10 out of 100 will have a movement response at laryngoscopy. And moreover, if you look at the straight lines of these interaction models, you see the BIS, this is the line for BIS of 40, and this is a BIS of 60. These are straight isobols. It's an additive interaction of propofol and remifentanil. And so you see that my expected BIS is around 45 with a combination of 4 propofol and 4 remifentanil. I dare you all to try this in clinical practice. I can predict that this will be, in the majority of your patients, you will have a very suitable induction with this setting. The problem is with the interaction models, you only estimate the average behavior in the population. And so we still missed a good monitor to help us to differentiate a sensitive and a resistant patient with a simple quantification. And then let's have a look what the NOL can do for us. Nociception level reflects also a time course of a changing stress level in the individual patient. It is based on many parameters. I'll talk to them about them in a second. But the majority of the parameters are depending on a balance between auto and parasympathetic nerve system. But they are quite sensitive to two features. Either an increase of the intensity of noxious stimulation will give a tendency of the NOL to be higher. And simultaneously, all our strategies that inhibit the intensity of the noxious stimulation, they have a tendency to decrease the NOL. So almost literally, the NOL index is a metric of a balance between nociceptive aspects and anti-nociceptive aspects in our anesthetic management. And that's quite a unique feature. It is the balance between nociception and anti-nociception we want to know. So how does it work? In the original study, the measurement is a very easy, non-invasive measurement where you put a finger probe on the patient, and originally a multitude of physiological parameters was detected. There was minimal motion or micro motion detections. The temperature of the skin was measured. There's a measure with a sticky part on the finger probe where you can measure the skin conductancy. And also the photoplethysmogram is measured. And from that photoplethysmogram, more than 40 different parameters were quantified. And all these multiple parameters were challenged versus a database of clinical events. And an artificial intelligence algorithm has extracted the best sensitive and specific parameter that could tell us something about stressful versus non-stressful conditions. It ended up with a NOL parameter who scales from, or that scales from between 0 to 100. And the advised optimal range for surgical activity is a NOL that fluctuates between 10 and 25, sometimes a bit lower. I'll come back to that in detail. Let's have a look to the original study where the NOL was developed, because that will give you the best understanding of what you can expect from this NOL index. It is a single number ranging between 0 and 100, and it correlates almost in a linear fashion with a very low variability with a parameter that is called the CISA. It is the composite index of stimulation and analgesia. And that's quite a clever idea, where on a mathematical basis, a quantification of stimulus intensity was defined. And this was defined according to this table, which is a categorical scale. You have clinical settings such as stitching or bladder catheterization, who were categorized based on experience from a number of experienced clinicians as a low intensity stimulus. There were other clinical settings that were defined moderate and noxious, severe noxious stimulation, and then also severe or extreme noxious stimulation. But you should be aware that this kind of stimulus was not included in the original study. And so you get the quantification. The more your stimulus is noxious, the higher the CISA will be. And this is compensated by an anti-analgetic activity, which is quantified by an effect site concentration of the opioids that were administered. There were several opioids administered, but they all were calculated into remifentanil equivalents. So the higher your opioid is, the lower your intensity of the noxious stimulus, and you get this CISA. You could have a high intense stimulus, with a lot of opioids that ends up with a low CSA. So this was a clever idea. And to be honest, because the NOL correlates to an index that includes both parameters, it really quantifies the balance between nociception and anti-nociception to some degree. And so in my mind, if I use the NOL, for me, it is a current metric for the activity status of the nociceptive involved neural networks. And some parameters in clinical practice, such as the presence of a noxious stimulus, the more intensity of a stimulus, they will activate this nociceptive neural network and give a rise in the NOL. And even if you extrapolate a bit outside of the original database, I have a tendency, but this is just a clinical impression, that in the awake patient, if you have a very stressed patient, you will see on average higher NOL values compared to the calm and relaxed patients. So there are several factors that activate your nociceptive networks. Others will inhibit your nociceptive networks, such as higher opioids, effective local regional blocking, adjuvant drugs. So as you will see, the NOL represents a combination, a spectrum of activity of which some is activating and some is inhibiting. The result is an index that clearly is able to give us information on the shifts between auto and parasympathetic systems. And in the first outcome studies, it's also confirmed that there seems to be a quantification that correlates to a stress response on the humoral level. But I think that still needs to be shown in future is that if you optimize your anesthesia according to the NOL and combine it with an EEG monitor for your hypnotic component of anesthesia, will you be able to lower the probability of a movement response? I'm not sure, because that's using a different neurophysiological pathway. Also, will you be able to reduce your risk for an arousal response on the EEG, which increases the risk for awareness? I'm not sure, it needs to be shown. But what I think is unique is that the noxious stimulus is kind of included into the algorithm of the NOL. And that's something new and was a bit of a missing link in our quantification algorithm. So even though that the single number of the NOL represents a spectrum of activities, if you guide your anesthesia, your opioid titration according to the NOL, there are already several prospective randomized control trials that show a beneficial outcome compared to normal clinical practice. So in the first study where they used propofol remifentanil in TCI, they already noticed a 30% decrease of the remifentanil consumption, the cumulative remifentanil consumption in a 2-hour anesthesia. And even throughout the surgery, there was a clear decrease of severity and duration of hypotension, which is an interesting outcome difference. In a subsequent study where they used sevoflurane and boluses of fentanyl, there was not much difference in the average fentanyl use, but apparently using the NOL leads to a more diverse titration of fentanyl over the population. So apparently the individualization of fentanyl was improved. And very interesting, the outcome on the pain scores, the immediate pain scores, were better in the NOL-controlled group. Very promising outcome study. And in the same study, you also see with blood sample analysis that certain stress hormones indicate that the humoral stress response was also less activated in the NOL-guided group. Very promising results. So let's go to clinical practice. Like I explained, if I start my anesthesia almost independent on what surgery I want to start, I try to aim for a probability of tolerating laryngoscopy in 90% of the cases. And so I start with propofol remifentanil 4/4. Or if I use another opioid, I use something that has the same potency. Then when the patient loses consciousness, I look at my BIS and I evaluate the sensitivity of my patient, and I adjust my propofol accordingly, so to aim for a BIS between 40 and 60. In general, that needs only one step adjustment. And simultaneously, I look at the NOL. If the NOL is low, below 25, I leave my remifentanil to my target for the PTOL 90%. However, if the NOL remains high, it's indicating that there's still a lot of stressful condition in the human body, and I increase my remifentanil before I do laryngoscopy. If my NOL is very low, I could consider to decrease my remifentanil, but I do not do that, because you still have to consider that in a couple of minutes, there will be an increase in intensity of noxious stimulus, and you should be prepared for the noxious stimulus intensity of the coming intubation. So what I will do is a laryngoscopy and intubate, or for the thoracic surgery, even put a double lumen tube, which has a massive stimulating activity. So I will not reduce my remifentanil because I want to maintain my probability of tolerance of laryngoscopy. I perform laryngoscopy, and that's an interesting event. This is the first noxious stimulus we administer as an anesthesiologist. At that time, we can have a look during 30 seconds, maybe even 15 seconds, whether there's a sudden response on the NOL. If I see an immediate response on the NOL, I stop my laryngoscopy and first increase my remifentanil. Because intubation has a higher stimulating activity than laryngoscopy, I want to prepare for a higher intensity of stimulation. So if the NOL does not increase, I remain in my remifentanil and I go to intubation. And then after my intubation, again, depending on the response of the NOL, I will start fluctuating with my remifentanil to keep a fluctuating signal on the NOL between 10 and 25. If you have used a bolus of fentanyl, you can't decrease your fentanyl very easily. So then often you see low values on the NOL, but that's compatible with the pharmacokinetics of your fentanyl. You would be surprised how low you can go with propofol and remifentanil in some patients. That's not something you cannot say, well, I have my monitors, I'm safe. No, it's a warning sign. It's a warning sign that you are dealing with a vulnerable patient, and you should stay vigilant. Watch your patient. If you do want to avoid movement and it's a very risky operation, consider full neuromuscular blockade. And so you go on towards incision and throughout maintenance. So evaluate the effectiveness of your locoregional block. Evaluate whether, if you add some adjuvant drugs like ketamine or dexmedetomidine, whether you can reduce your opioid. These are all features that you can do using the NOL. So what do I expect with this clinical approach on outcome? And I have some evidence for that. First of all, I think by doing this effort, optimizing my hypnotics and opioids, I expect less hypotensive events during induction and during maintenance, both in severity and duration, especially with the propofol remifentanil condition, because that's the same setting as in the prospective randomized controlled trial of Leiden. Secondly, I expect a lower humoral stress response after surgery, which has some evidence. And further on, I titrate just enough to do the job. I try to individualize the titration, so I expect a little less remifentanil on average. And for the fentanyl, I think I will optimize the individualization of my opioids. And also, I hope to have lower pain scores at the PACU. I think there is some evidence for that. And so maybe less strongly supported by research, but still clinically convincing, is that it helps to check your effectiveness of your locoregional block. It certainly will indicate if the surgeon gives a noxious stimulus above the level of your epidural block. It will warn you for unexpected changes in a noxious stimulus intensity. And it will help if you want to give a combination of adjuvant drugs to reduce your opioids. It will detect some effect on the NOL. And that's where I want to finish my small introducing talk. We have, together with a sponsorship of Medasense, we have had the opportunity to film a case where multiple cases where we use this technique in clinical practice in our hospital in Bruges. And so I'll invite you to watch the YouTube movie that we have made during that event. I thank you for your attention.